I wanted to talk about something we all probably know a bit about, or quite a bit about, management of small renal masses. And I'll explain a little bit why. So, I think renal cancer is essentially an aortic operation, and control of the vascular anatomy is the cornerstone of everything we do, really, I think, in renal surgery and regarding operations on the kidney. And small renal masses, I decided to make the focus of this presentation because we see them every week. We discuss them in the tumour boards, or in the UK, we discuss them in the MDTs all the time. I think there's lots of different ways to manage these sort of little lesions within the kidney. What I really want to do is go back to basics a little bit for the first half of the presentation, discuss these sort of things, and review the current, not the previous, but what we know now from the evidence base. And then for the second half of the presentation, talk about surgery, so partial nephrectomies and some of the nuances there with a colleague from the UK, because we're all surgeons, so I wanted to dedicate some of the presentation to surgery as well. And I think this article here was published in the BJUI last month, I think it was, and it's been compiled by a number of kidney experts from the UK, some from Europe, North America, including Canada. And when I read this, I thought it gave a really nice framework with which to sort of think about small renal masses and review the management and the evidence, which underpins it. And they put it together in a sort of case study format. So I'm unashamedly going to use their case study to sort of form the backbone of the presentation, and then just move on from there, really, and present different points for and against, maybe different management strategies within the context of a clinical case. So like I said, the first half of the presentation is going to be to quickly outline small renal masses and then move straight onto the case and discuss management. So we'll discuss surgery, spend the most amount of time on the renal mass biopsies, quickly discuss some novel imaging techniques, sestamibi and girentuximab scans, a slide on ablation, a slide or two on SABR, and a slide on active surveillance. And then the second half of the presentation will be more specifically about partial nephrectomy, and doing this using the single port robotic Da Vinci system. There are other systems available, mainly focusing on the retroperitoneal approach, and that will become clear. So the incidence of small renal masses. So small renal masses, so less than 4 centimeters, T1A. These are the most incidentally detected small renal lesions, and the incidence has increased almost 3% annually from 1975 to 2007. So we're picking up more of them, and we're picking up them more often as a consequence, as we all know, of increased abdominal imaging. But the increased detection hasn't really translated into a decreased mortality. There's possible explanations for this, maybe in part due to the fact that we're overdiagnosing and over-treating clinically insignificant or sometimes indolent disease, possibly. So it's important to remember, I think, I've put a little a stat up here, reference number 2, that almost a quarter of small renal masses are actually benign on histological review after we've removed them. And as we all know, size matters. So we know that the bigger it is, the higher the chance there is of it being malignant as well. So when we remove these small renal masses, what do we find? Well, like I said, a quarter of them can be benign. They tend to be less aggressive subtypes and usually lower grade. So 80% of T1A lesions are only a grade 1 or 2. And we know that they have a low metastatic potential. So less than 1% over 5 years of grade 1 and 2 small renal masses metastasized on active surveillance. So this is our case. And I wanted to do a quick little poll and see what everyone's sort of management option would be when I just present the case. But the technology is just too much for me. But maybe have a quick think in your heads. So this is a 63-year-old gentleman. He presented to his primary care physician with an incidental CT finding of a 2.9 centimeter left renal mass in a congenitally solitary left kidney, something that the patient was previously unaware of. And this was discovered as part of an emergency department evaluation for an episode of epigastric pain, which is now completely resolved. So he's an unmarried school teacher. He's overweight. His BMI is 29.7, and he has well-controlled hypertension on atenolol. He's got no other sort of significant history, so no smoking history or occupational exposures, no relevant family history, and he denies any urinary symptoms, hematuria, flank pain, constitutional symptoms, or anything like that. His blood pressure is in the normal range on his atenolol, and physical examination reveals moderate central abdominal adiposity, but no palpable masses or any scars. He's had a full blood count and comprehensive metabolic workup, which was all normal. His urinalysis was normal, unremarkable, and his creatinine was 88 and his GFR was 75. And you can see his CT scan here. So he's had a contrast enhanced CT scan. So it includes images with and without the contrast in the arterial phase. And there's a 2.9 by 2.7 centimeter enhancing exophytic renal mass arising from the posterior interpolar region of the left kidney, and he's got a renal nephrometry score of 8. The mass briskly enhances, it's well defined, and it's predominantly solid. There's no signs of any sinus or vein or any sort of perinephric fat invasion, no lymph nodes. And as we know, the contralateral kidney is absent. A diagnostic chest x-ray was unremarkable, and he comes to clinic because he wants to know what our opinion is regarding the best course of action for him. So I think these are, broadly speaking, our options. So we've got the first decision point is whether to undergo further diagnostics. Do we need some more information, or would we like to have more information? And that's probably going to involve a renal mass biopsy, but I'll also mention specialist nuclear medicine scans as well. Or just to proceed with immediate management, and that could take the form of surveillance, surgery, different approaches, ablation, so cryo RFA, or SABR. So why could we decide to take him straight to surgery or just remove the mass straight away? Well, he's had a CT scan, and that's a great test. So the sensitivity for malignancy for a small renal mass is almost 80%. Maybe there were concerns around morbidity and the accuracy of a renal mass biopsy, but we'll have a chat in a minute about whether these concerns are valid or not based on the current evidence. And active surveillance has its drawbacks. So the patient's fit at the moment, and by waiting, we run the risk of sort of losing that optimal window for surgery, because patient factors or tumor factors can change and worsen over time. And I think also, given the heterogeneity of RCC, surgical section is probably our best way, a lot better than biopsy, for informing on disease biology. But ultimately, it's quite high-stakes surgery. He's only got one kidney. So I think in most centres, we're definitely sort of in the UK, all of these cases go through an MDT, and the management will be centralised. So what about further diagnostics? So I'll spend the most time in a few slides on renal mass biopsy, because I think it's interesting, a little bit interesting. First of all, just what do the guidelines tell us? Well, the EAU guidelines, I always like the EAU guidelines. They have a strong recommendation to perform a biopsy before ablative or systemic therapy. And the CUA guidelines say that patients should be offered a biopsy if the results might alter the management. So it's an option. I think that's the summary of the guidelines. It's an option, a reasonable option, probably a good option to consider at least a renal mass biopsy. So a lot of the guideline recommendations, which I've just mentioned regarding renal mass biopsy, have been informed by this study published by Marconi et al. In European Urology, I think in 2016, 2017. And we can see that contemporary data shows that renal mass biopsy has very high sensitivity and specificity, with a very good concordance to the final histology, but quite poor concordance to the final grade of the tumour. Complication rate is extremely low, and the rate of serious clavien-dindo complications, so 3 or more, is really very low indeed. So in terms of complications, whether we should biopsy or not, well, there was the largest meta-analysis to date. Only 3 out of 5,000 patients had a clavien-dindo score of 2 or higher. And if we compare that to surgery, so from a British national database of almost 6,500 patients, clavien-dindo 3 or higher complications in an open partial nephrectomy was 6%, and a lap or robot partial was 4%. And that's real world data. So that's sort of what we see in practice. I think tract seeding just isn't a thing, really. There's only ever been one properly documented case. It's more anecdotal, and they didn't use a coaxial sheath when that occurred. Okay, so thinking about biopsy or not, I think it's an almost universal standard diagnostic step, interestingly, through all surgical specialties before consigning someone to an operation. And it's also really useful for risk stratification. But only 16% of small renal masses were biopsied preceding surgical treatment, and that data comes from the National Cancer Database in the US. And the sensitivity for CT for small renal masses, I said it was very good earlier because I was sort of selling surgery. It was almost 80%, but it is 80%. So there was a sort of, there was a reasonably significant margin for error there. And if we think about other lesions other than renal lesions within our own specialty, I think there is other outliers, potentially testicular masses. We don't tend to biopsy those routinely anyway. But I think that's a different situation. There are valid concerns there with altering the lymphatic drainage, the very high specificity for testicular ultrasound, and the aggressive nature of disease if left unchecked in testicular cancer. There's also the availability of tumor markers there, and the low incidence, about 8% of benign pathology. So I think it's interesting, and I don't know, perhaps maybe it has a historical basis as to why so few renal masses are biopsied, particularly given the current evidence on safety of renal mass biopsy and the high rate of benign disease for small renal masses up to a quarter. So it's just, I'm not saying there's a right or wrong, but it's just good to know the evidence and food for thought, I think. So what reasons do urologists give for not biopsying? Well, the first one is it won't change the management. Studies have looked at this, and we actually know that renal mass biopsy does reduce the procedure rate by up to a quarter, or about a quarter, and only 3% of lesions needed a procedure within 6 years. There's also evidence from the Disarm registry, which is a prospective trial published in European Urology 2016. And what that showed that the cancer-specific survival rates were similar between active surveillance and surgery at 5 years. And other sort of reasons that urologists give for not doing a biopsy is it's not accurate enough, or we've spoken about that, and patients might get a complication. which is true, but we've spoken about that as well. So I think to sort of in summary, what the current evidence tells us about renal mass biopsies is it's safe, it's accurate, it reduces the need for unnecessary surgery in some cases, and it doesn't affect the surgical outcomes. But I think, I'm not sort of saying biopsy, 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 but I just wanted to present what we know and what we have at the moment. And it's not right for all situations. So I think someone said to me once that if you're going to sit in front of a patient in clinic following a partial nephrectomy and there's going to be regret on sort of your part or their part that the pathology was benign, then that's probably quite a good barometer for performing a biopsy. But if a patient's just going to be relieved either way that you've removed their renal lesion, then it's probably not necessary to go ahead and biopsy. And I think that's quite a sort of a helpful way to think about it, really. So just a slide each on these more sort of novel imaging techniques. So in terms of diagnostics, so other imaging we could do is sestamibi SPECT CT. So sestamibi is already well established in other diseases, so cardiac, parathyroid, breast diagnostics. So we already know it's safe. There's only been one case of allergic angioedema in the literature, and there's lots of real-world data and experience supporting its use. It involves technetium-labeled sestamibi, which is a lipophilic cation taken up by the cells which have high levels of mitochondria. And things that have high levels of mitochondria that are relevant to small renal masses or renal masses are oncocytomas, which are the commonest benign renal lesion. So RCC has very low levels of mitochondria relative to normal renal epithelial cells. So oncocytomas appear avid, and RCC, particularly clear cell RCC, is photopenic. So that's sort of how it works. So its aim is to avoid renal mass biopsy altogether and avoid unnecessary surgery. And I think that's important because although conversion rates from a partial to radical nephrectomy are very low, ranging from about 0.7 to 5% in the literature, it would be a disaster for a patient with a solitary kidney, consigning them to a life or a shorter life on dialysis. And the second scan I wanted to mention is the girentuximab PET CT. So this sort of works in the opposite way almost. So over 90% of clear cell cancers are characterized, as we know, by the mutational loss of VHL, and that leads to dysregulation of HIF1 alpha downstream and overexpression of carbonic anhydrase 9. Now, carbonic anhydrase 9 is a cell surface receptor, and that's expressed in over 95% of all clear cell renal cancer, and it's not present in normal tissue. But I think there is a slight expression in the biliary tract, that's all. The main practical downside of this scan is the dosing. So there's a 3 to 7 day delay between dosing and then performing the imaging. So the patient needs 2 trips to the hospital to facilitate the scan. So that's logistically not ideal. The scan is good at telling us, firstly, if a lesion's malignant, so specifically clear cell RCC, most malignant, and it seems to outperform CT in terms of sensitivity and specificity in this area. And it also gives us some insight into the tumor biology as well, looking specifically at aggressive clear cell subtypes. Studies have also found that the interreader reliability was good, and it's just as accurate at small lesions of about 2 centimeters. But I guess with some of these scans, logistics is an issue, or can be an issue. So those are the other diagnostic steps that we've looked at. So patient wishes to have a biopsy, they've decided before making any more decisions. So percutaneous biopsy is performed, no complications. Patient has a grade 2 clear cell RCC without any variant histology. So they've scheduled a clinic follow-up appointment to ask us what our opinion on treatment is. So these are the options now. So surgery, which we should have already discussed, ablation, SABR, and then active surveillance. So they could have a partial nephrectomy. I think some of the sort of, I don't know, the indications or the argument for the surgery is that it's a grade 2 clear cell RCC on the biopsy. So it's got the potential to grow and metastasize, but we know that biopsies aren't good at grading tumors. So its final pathology could upgrade it into a higher grade or grade 3 cancer. In terms of the surgical approach, could do open or robotic. I think high volume centers would probably take this on robotically. That's just, I think approach is just due to surgeon experience. I don't think it matters too much. Solitary kidney, bigger kidneys, so it's probably a bit more resistant to ischemia. Could use segmental clamping and 3D modeling. That might be helpful. Lots of places do that. And then the other thing to think about is, do you leave a drain or not? Probably not routinely, but this is higher stage surgery. Maybe some extra monitoring might be useful. So could consider a drain. Image guided ablation. So although I think partial nephrectomy is probably the gold standard for T1A small renal masses, ablation's good as well. I think there was a recent systematic review in St James's Hospital in Leeds in the UK, which included almost 75,000 patients. And as we'd expect, the ablation patients were older and they had a worse overall survival. But if you compared them at 5 years follow-up with partial nephrectomies, their local recurrence-free survival, MET-free survival, and disease-specific survival was very similar. They also had less loss of GFR, so they lost about 7.5 GFRs less than patients who had a nephrectomy. So what's in favour of ablation? Well, his nephrometry score is 8, so moderate risk for surgery, so maybe ablation could argue might be a bit safer. Comparable oncological outcomes and lower decline in GFR, but there are complications with it, so you could get pneumothorax or injuries to genitofemoral nerve, and the efficacy reduces for ablation in tumours over 3 centimetres. SABR. So I think maybe not in this case, but if, for example, the patient declines surgery or has some sort of anaesthetic contraindication, then SABR might be a really good alternative for them. In its favour, it's non-invasive, nephron sparing, and it can be performed in the outpatient setting. And there was a study or a clinical trial called Fast Track 2, which was published in The Lancet Oncology last year. And they found that local control was 100% at 43 months. Most of the cancers were a little bit bigger. They were T1B, and median size was 4.6 centimetres. And the renal function loss was comparable to a partial nephrectomy, so about 14.5 GFRs. Another systematic review published last year in the Lancet Oncology as well found that the local control was about a little bit low, 94%, and the median tumour size was 4.4 centimetres. Good things about SABR, it's not limited by its proximity to key structures around the hilum, but bowel contact is an issue for it. They're just some of the considerations. And then hot off the medical press, this systematic review, a meta-analysis was published just this month, actually, in the Lancet Oncology. And it showed that local control rates for SABR were 99% at 1 year, 97% at 2 years, and 95% at 5 years. And this was superior to RFA in cryoablation. The patients for SABR were older. They had a worse starting GFR and larger tumour size than the ablative cohorts. So I think SABR is starting to, there's a bit more evidence now, isn't it? Starting to stand up to some of the more established nephron sparing options. And then finally, finish off this sort of section of the presentation, active surveillance. So this management option was first suggested based on autopsy findings of incidental RCC and retrospective imaging reviews, where apparent RCCs sort of were unchanged over many years. They were also found to have very low rates of progression to metastasis, and the local progression of biopsy confirmed RCC is quite heterogeneous. So we know that few of them grow rapidly, but growth rates do vary based on the histological subtypes, and growth can occur at any time. There isn't really an agreed surveillance protocol to follow these patients on active surveillance of small renal masses, but most patients will get imaging at least initially every 3 to 6 months, maybe cycling between CT and ultrasound. So active surveillance can be quite an attractive option, I think, but perhaps more so for the elderly patient. But in this case, where we've got a relatively young man with a long life expectancy, active surveillance, probably not one of the front runners for him, but an option nonetheless. So now a little sort of, that was an overview of small renal masses and back to basics a little bit, but with a sort of hopefully an up-to-date look at the sort of evidence base that we're working within. I want to take a little segue slightly. So still focusing on management of small renal masses now for the next sort of 20 minutes, but just focusing on slightly more niche or sort of upcoming use of the single port robotic system. I'm not going to talk too much about this, but I'm going to, because I don't have very much experience at all with single port systems. I think I used it years ago doing general surgery laparoscopically, but that's completely different to what we have now. So I spoke to somebody that does know a lot more about this to try and get a little bit of insight from them about the pros and cons from their point of view. And I think some of the questions that came to mind straight away with single port are, is it just about cosmetics? Does adding an assistant port ruin the advantage of the single port system? Does it just make it obsolete, a waste of time? And is it essentially surgery of one hand tied behind your back? So you're making something that's already potentially challenging it even harder by adding a single port component to it. So I'm going to try and switch over now to a video. Thanks, guys, bearing with me. Quick introduction. Mr. Deytrikhm is a consultant urological surgeon at Guy's and St Thomas's Hospital, which is in London, specialising in kidney and prostate disease. And I believe is the highest volume partial robotic nephrectomy surgeon in the UK. Ben is also the Uro-Oncology Fellowship Programme Director at Guy's and Tommy's as well. So thank you very much for joining us. Very
pleasure. Thank you very much for inviting me. Nice to chat about things I'm passionate about.
Excellent. Thank you very much. So I'll just kick off then. So I read there's about 10 single port robotic systems over about 5 different countries in Europe, more in America. And I understand that you were one of the first people to get going with this in Europe. So I guess given your significant back catalogue in using the multi-port robotic system over the years for kidney surgery, what were the challenges? Was it particularly sort of traumatic moving from one to the other or incorporating the single port system, or was it quite seamless for you? How was the learning curve from your perspective?
Well, I mean, just to give colleagues some background to this, in the USA, this robot, I believe, has been around since 2018. I think COVID stopped its launch in Europe a bit, and so it got CE marked about this time last year. And so there was a slight sort of land grab race across various different centres to try and be the first ones ones to use it. We weren't the first. The Karolinska just beat us to it by a couple of days, but I think I was the first who did any kidney surgery with this robot. Not that any of these things are really important. And we also did some transvesical surgery. So in the Europe at the moment, for reasons I'm not totally understanding, the Italians love it. I'm going to the first European SP meeting in a couple of weeks, and I think there's 7 Italian centres. They love and the partials. They've also got it at the Martini Clinic in Germany. They've got some in Belgium, and we've got one in London with us, which is in a private hospital. One in Aintree, Liverpool, which is for transoral bought it, but urology started using it, and they've got one in Dublin, where they actually bought it for breast cancer, for nipple-sparing mastectomy, would you believe it? And again, because of that grant, the urologists are trying to get on that. So I'm not an expert on this. I would still be really classified as a beginner. I've done about 50 cases, 48 cases.
Okay. Yeah. And how did you find starting off?
Well, I suppose also I should say that in our institution in the last 3 years, I've also learnt the CMR robot and the Hugo robot. So the first new thing we learned was really tricky, learning a new robot. I've done about 850 partials, and to start learning to do something with a completely different system was with the CMR was tricky, and then with the Hugo that was less tricky, and I think with the SP I was just desperate to kind of get going. But unlike the others, which are all multi-port robots, this is conceptually, mentally a little different. And it breaks, I spend a lot of time teaching people, as you'll have similar with your mentors, about how to do different aspects of robotic surgery, about don't turn, don't affect the horizon. You've got to stay straight. You can get lost. In this robot, you're actively encouraged to kind of drive it round like a plane round corners.
Okay, yeah.
You haven't got a fourth arm. You can't think of it as a fourth arm, and you've got 3 arms. So you've got a left, a right, and an upper, or a left and a right and a lower.
Yeah.
And often you will use, for large parts of the case, the lower and the right, or the lower and the left, and the other one will just be retracting. So some of the concepts that we kind of spent our life sort of dealing with in normal sort of multi-port surgery go out the window with this. So there is a little bit of a mental kind of jump to how you can best do that. And I think you need to play with the simulator quite a lot beforehand, before you get going.
Yeah. Okay. So I guess following on from that then, so I read that about 8% of the partial nephrectomies in the United States are done with a retroperitoneal approach between 2016 and 2018, so quite a small proportion. And just about retrosurgery generally first, I think when I've seen it, it just looks tricky to me. So getting in the right space, blowing it up, the anatomy looks different. I think it just looks easier to get lost, and that's probably to sort of the untrained eye. And I think one of the great things about robotic surgery is probably that it's become quite reproducible. So you don't have to be, a really exceptionally gifted laparoscopic surgeon to sort of pull off tricky cases. It's more that I think robotic surgery seems to have been, certainly training on it, more of an enabler. So sort of the rest of us, in inverted commas, can have a go. So with that in mind, what challenges have you seen trying to train people to do retro surgery, and maybe retro single port surgery, either consultant colleagues or other sort of urology training coming through? Is it difficult? Do they find it difficult, the learning curve?
I think you need to bear in mind when you start with this robot that it is you can't do everything with a single port robot that you can do with a multi-port robot. However, in my mind, I thought we're looking at about a quarter to a third max that we're going to be able to happily do with this, and it's turned out to be more like 2/3.
Okay.
Great. So that has been a sort of mental sort of jump with what as we've evolved into the program. We've always done some retroperitoneal work, and indeed I've got a few colleagues who send me cases because they need to be done retroperitoneally, but I'm not retroperitoneal surgery was not my go-to approach.
Okay.
It was something that we would use if someone had a stoma, previous laparotomies, Crohn's disease. I would rarely choose it just because the tumor happened to be on the back of the kidney. As in, my default was always to go trans. However, with single port, of course, the retroperitoneal and extraperitoneal, what we can broadly call regionalized surgery, becomes much more attractive, because actually the single port is only half about being a single port. It's half about sneaking in around the back or down the side.
Okay.
And I think that's when I kind of got it more as to why people were trying to do single port, because you get the benefits of staying outside of the abdominal cavity in terms of ileus and pain and early eating and all of that. Plus, you get the benefits of having a one small hole. So, or one medium hole compared to 5 holes. So, I think for me, it's the double whammy, if you want, of staying out of the cavity and using this very cool little robot that can get into a small space.
Okay, yeah, got you. So I think you've answered some of my next question there, but I'll be quite direct with it. I was listening to a popular urology podcast, which I think you've been on at some point, but this particular one was focusing on single port robotic surgery and talking about the kidney as well. And I think that the more I listened to it, the theme I got from the panel was that maybe they're not completely convinced that the single port system is ready for prime time yet. And some of the questions they were asking, as I think you've sort of alluded to, are whether actually it's good for cosmesis because there's less ports, but maybe it's making already tricky surgery a bit more tricky. They even sort of tongue in cheek, I think one of the comments was, the best part about doing a single port case is when you go on to do the multi-port case next, and you realize how much nicer the multi-port system is. So, and I think maybe part of that was because of the endo-wrist, sort of loss of the endo-wrist stability, which I've heard about. But what sort of cases come through the MDT, the weekly MDT that you look at and you think that would be ideal for a retroperitoneal approach, and the single port system would be particularly useful there? And I think you need to stomas and Crohn's and things, but what cases are you picking?
I think it's in terms of what I'd call nothing more than an 8 out of 10 difficulty partial, but by renal and Padua scores, that would mean that you'd go to sort of you'd go 7, 8, 9s, 10s. You wouldn't do 11, 12s with this. So I think it needs to be at least partially exophytic. It needs to be on the posterior, the lateral rim or polar. You can't have a tumor that's in the hilum that is anterior in the hilum, because you're just not going to be able to get at it. And of course, if you start thinking about doing this, you're essentially, when you're resecting the tumor, normally you've got one hand cutting, one hand lifting, and the assistant usually on a downward traction, giving you counter traction and sucking aspiration. Here you haven't got that. I call it like a buffet surgery. You have to serve yourself. Yeah, so you've got a little rosy sucker in it, or some little infant feeding tube type device with a suture on it, and you're grabbing that. So you need to be able to help yourself more. Okay. Your fourth arm or your other arm, or your in retro surgery is usually your upper arm is usually holding up. Mm-hmm. But that arm is really just holding the space up. So you're really then doing the whole thing with 2 hands. So the suturing, I think, is fine, because you usually do that with 2 hands. But the actual resection of the tumor, you've got to have a plan that is pretty robust, with a backup plan before you start. As in, I've started leaving like a tuft of fat on the tumor, just so that the arm above can lift up, but it can also grab a piece of the tumor. Then it can angle that. You've got to remember to switch between the arms quite a lot to get the maximum benefit out of it. And if you want someone to suck, usually that's going to be you, and you've got to go and get it yourself. So I think, like a lot of surgeries that we and other specialties do, this is one of these ones where it's a little bit more technically challenging, but the results are great, and the smiling face of the patient the next day, potentially walking out the same day, which is really attractive, for these kind of cases. Yep. Is what kind of drives me on. 3 robotic prostates with ASP in a row, that's a hard day. There's no doubt that is quite a challenging day. The kidneys are quicker, because you're onto the vessels very, very quickly with the retroperitoneal approach. It's kind of made me fall back in love with retroperitoneal surgery generally again. I've started doing some with the Hugo now retro, which not many people do, because they just, they were nice cases. Big high BMI patients, that's tricky. So I think the big no-nos for that would be a very complex tumor, an anterior tumor, a totally endophytic tumor, or a BMI over 35 in a man, certainly. If a woman has got a lot of external fat, but not very fat inside, you could probably go higher than that. But I think, as I said, I've done 48 cases, 49th tomorrow morning. So I'm, not, we haven't pushed the envelope because I don't want to have that moment of, I'm really sorry, could you get the other robot in, please? I'm struggling a bit here. Yeah. And you can't be doing that if you're on clamping a partial. So it's a stepwise progression.
Right. Okay. Oh, that's really interesting. I think, and the other thing you mentioned there was getting, maybe less pain, getting people out, more day case surgery, which is obviously quite important, maybe a selling point within the system we work in the NHS. Okay. Yeah, good. And what about sort of sidestepping a little bit to sort of more maybe a couple of granular questions about the technical aspects? What approach do you use? Is it a flank approach or low anterior? And do you still have to prepare the space with a balloon?
Yeah, no, all good stuff. Well, I would say number one with this is that my understanding, speaking to a lot of friends, American friends, and colleagues who I've worked with and done papers with and stuff, when they started with the SP in the States, they didn't have the access port. It was down a actual metal port, which gave you much less flexibility. All your forearms went down that one port, and you then had to just do everything you could through that port. The access port, which you'll see is like a little sort of tent, a little balloon, that you can get the sucker down, you can get specimens out, you can get needles down it, and so you can drop stuff in and out of that, and you can use it as a holding place for pathology or bits of fat or whatever. So it gives you much more flexibility. So what we've done, and I think what Intuitive, because this is an Intuitive robot and they're good at this training pathway, have decided is that when you start, you do some trans, which seems weird because you've got all this space and this tiny little robot and you don't really need all that space, but that's just, you're only changing one thing, which is the robot. Everything else is familiar. And you do the retro. And then after a while, we go back to the lab. We went back over to URCAD, which is in Strasbourg. It's a sort of one of the big European lap robot training centers. And that's when we learned the low anterior. And for me, and colleagues who don't know, low anterior, I'll send you some slides on that so you can show, after doing 20 years of lap robot surgery, if someone's to come up with an entirely different way of accessing an organ is just mind-blowing, really. I don't know how they consented the first person and said we're going to have a go at doing a completely different route. Yeah. But basically, you do almost like a McBurney's point scar right down at the sort of, at the level of the anterior superior iliac spine. Basically in a woman, that would be almost under the sort of bikini line. And I would say that is the absolutely perfect or the best way that you could do, for instance, a pyeloplasty. Okay.
And I understand there's a pine as well.
Yeah. The anaesthetists love it. They're on their back. You put a little bean bag or something, just a bag of saline wrapped in a gauze underneath them, just to bring the kidney up a little bit. And so for a nephroureterectomy, if you're doing that, a benign nephrectomy, a small malignant nephrectomy, like a totally endophytic tumor, or a pyeloplasty, it's beautiful because basically it's the least impactful surgery that I can see. The scar's in a great place, and it's what you might call, for the kidney stuff, it's extraction surgery, as in the size of the hole is exactly the size that you need to make to pull the organ out, and no more, not a half a centimeter more. So we've done a few nephroureterectomies with that, I think 5 of those, and it's been, that's been a complete game changer. You can do a para-aortic paracaval lymphadenectomy. You can stand the thing on its head and it goes down, and then you take out the lower end out of the bladder. So I think, for those cases, the SPs are not doing something in a more difficult way. It's a real step forward, but not for all cases. Some cases, of course, are more tricky.
Oh, yeah. Okay. Oh, fantastic. All right. And then I think probably finally, using the SP system, does it change the dynamics in the operating room at all? So are you out there on your own now, sort of in splendid isolation, doing everything yourself and getting on with it? Or do you still have an assistant port for, bulldogs or ultrasound to come in? What are you doing? Or does it change the feel or the assistants in the theatre?
Yeah, it does. It does change your relationship a bit. We have surgical care practitioners, as in professional assistants, who help us both in the NHS and privately, who we are usually very reliant on. They've now got very good at manipulating the SB system, docking it, setting it all up, targeting it. But actually, in the operation, of course, they can't help you very much because you are on your own. If you're just doing a pyeloplasty and it's fiddly, they can't help you at all because I have no other port. It's just one low anterior approach. But for the partials, for the reasons that you said, bulldogs, there is in Europe there are tiny little gold bulldogs that are Scanlan but mini, and they're only licensed to FDA American licensing. They haven't got CE marks. I still have to use the larger bulldogs, which means I have to put in one port.
Okay.
And for the partials, I'm living with that, and that's just the way it's going to have to be, to have it one port to put in the ultrasound, the bulldogs, a sucker, and the clips very easily. And so I'm not quite brave enough to start doing single port off clamp type things yet, but we'll get there.
Okay, great. All right, lovely. Well, Mr. Tanneken, thank you very much for sharing your insights with us this evening, particularly on a Sunday evening for you.
Pleasure.
So I'll let you get back to probably, I don't know, catching up with the Six Nations highlights or whatever you've been doing over the week.
Yeah, that's not gone so well for us.
Not, yeah, if it's even worth watching after the England Ireland result. But thank you very much for your time.
Pleasure, and I hope the rest of your rounds goes well. Cheers.
Lovely. Thank you. Cheers, mate.
Okay, thank you very much, guys. That brings us to the end of the presentation.